Hey everybody, this is Khara Brindle. Welcome back to another video with three of my amazing colleagues, familiar faces. Good morning. Say hi, everyone.
Morning.
Hi.
So we wanted to come on a video. This has been popping up on social media groups a little bit more often recently of what is medical necessity. So we want to talk about how it's defined. We want to talk about where it's documented and even some of the language of how it might be documented. So I know each of us have had to navigate this in our own way as group practice owners, but also from insurance perspective. So Alex, I'm going to have you start us off by talking about where
Yeah.
you've seen medical necessity show up.
Well, at Life Recovery Centers, as you guys know, we now opened up intensive outpatient services. And so when we have a client that comes in, we do an intake. And upon the intake, we have to determine based on ASAM criteria. For those of you who have substance use disorder licensing with the state, we have to complete the ASAM, which has different dimensions and these determines what level of service the client falls into. And then based on the score, we have justification for placing them in intensive outpatient, enhanced outpatient, or just regular outpatient. And that determines the level of contacts they have, whether it's one contact a week, two contacts a week, three contacts a week, ranging from 2 hours to 9 hours a week, depending on medical necessity. For example, we have kids that were referred to us that they meet criteria of inpatient placement, but in the state of Colorado, there is no inpatient facility for kids who have dual diagnosis. And so Medicaid comes back and says there's a medical necessity for services. So if we don't have this service right now, we're going to override the 3.5 and have them be in a mental health facility with intensive outpatients because there's medical necessity and clinical justification as evidenced by the assessment that they are in need of these services. And so when we document it, we do the ASAM, we put that in our electronic health record, and we submit it to Medicaid. They come back with the approval. We upload the approval. That's the key piece. Upload the approval into the electronic health record. And once you get that approval, when you submit the bill, if there's any discrepancies whatsoever, we have the Medicaid or the insurance approval for the level of care with the date, and so they can to remediate that. And then when they say, well, we want to see the assessment to see if this is clinically justified, they're able to see the assessment and see that yeah, we did our due diligence with the assessment, the the scoring, and with the diagnosis to justify the services that are being given to the client.
Right, right. So I'm hearing like kind of the golden thread on steroids of like there's really a
Right.
lot of paperwork pieces here that justify that level of care. So I know for folks who watch this video who aren't in the substance side, this is where Jen and Liliana, I'm hoping to hear from you as well, of how do we document medical necessity as like outpatient private practices that don't have intensive branches like Alex's business. Thoughts from either of you?
Yeah. Wow, that's a whole lot of paperwork, Alex.
Oh yeah.
Um, wow, I feel like my brain is okay. So yeah, ours looks different. So Realistic Serenity, also an insurance-based practice, also accepts Medicaid and all of those things. I feel like every insurance has its own distinct
Mhm.
little hoops to jump through.
Yeah.
So that's another facet of medical necessity that we kind of struggle with is you kind of have to know. It's almost I hate to say it, but I'm going to say it. It's how to play the game. You need to
Mhm.
know how to play the game for each insurance. So what's different with us is we primarily see children and adolescents, and so for us, nobody's thrilled about diagnosing a 4-year-old with anybody with anything,
Mhm.
right? But we have to because of insurance reasons. And then the additional layer for us is that we work with so many kids that are in the LGBTQ community. So we come up against medical necessity more with diagnoses, I think. So for a long time, and I don't think this is the case anymore, I think it's fixed, but we could not put gender dysphoria as a
Yeah.
diagnosis because this was a medical condition. Problem is that the medical, like, medical, physical medical community looks to us to make
Yeah.
sure that these individuals have medical necessity for the treatments. So it's kind of a back and forth. If we
Mhm.
put gender dysphoria on a claim, the insurance company will kick it back and say, no, that's not what you're doing. And some and some vein that's kind of true. We are not, we're treating maybe the anxiety that comes for it, or maybe we're treating depressive symptoms, or we're working on the family to like come together. Like that's true. We are doing all those things. But they're going to want us to write a letter that has on it. And so then it's kind of like, well, how do we document if we can't have that there as a diagnosis, but they need that specific diagnosis to be able to do XYZ when we're talking about, hormones and surgeries and things like that. How do we document all of that while I don't know, I guess kind of playing the game. The same thing with kids who are on the spectrum. They do not want us putting autism spectrum disorder, which again, true, we are not treating autism. We might be treating social skills. We might be treating like a ton of things that might coincide or go with that. So I think that's the medical necessity piece that we come up against much more. It's just how to kind of know what everybody wants and as far as documenting and where and what box we have to check and what specific language that we need to use to make sure that our clients are getting what they need and we have all the bases covered.
Yeah, lots of admin. Liliana, I see you have thoughts.
So many. So let's just name it because I love the genuine here, which is we have to learn how to play the game. Because we're using systems and systems do not want to pay for services. That's why they require that we provide evidence-based models. And when we are talking about medical necessity, either if you're working with Medicaid or with insurances, you have to read the manual to know what are the assessments that I have to do in order to prove the medical necessity for the client. Once we do that, and usually very basics are like depression, anxiety, trauma, like we have to have something in order to do so. And then we have to also talk about what interventions can I do with this client. And again, it has to be evidence-based so that the insurance, the Medicaid, the system overall will feel comfortable saying like, okay, you have a plan. These are the assessments we can go ahead and approve. Jen is absolutely right. Most of the time is how this is going to affect the client. And most of the time we give a diagnosis, but we're working with the symptoms of, and we're working with system like the family. So we may have a client that whatever they're going through, in this case, either a child or a couple or an individual, and how is this affecting their job, their family relationships? Like it's all these things that come into play that insurances or systems will say, yeah, but is this unnecessary? Do I really have to pay for it? And that's what my rolling eyes, because that's how we as therapists have to learn what language to use and how to play ball in order to get the help that our clients need.
Yeah, I mean, that's what I'm hearing from all three of you is this is really a lot of admin on behalf of the client and truly believing this is going to benefit them or help them in some way. Otherwise, I would feel like this is a lot of work for nothing, right? The other example I'm hearing in my head that I think is showing up in these groups is medical necessity that is sporadically like an increased level of contact with the client. So like they're probably in crisis. So I'm thinking of our colleagues who are like strictly outpatient, mostly like functioning clients, probably on some level, however we rank that. And they're saying, hey, I want to bill an extra session a week, or I want to start seeing them more frequently because they're going through something. How do I indicate medical necessity for that? So unlike the three examples you've all given of like the start of care and doing these formal assessments and diagnosis and all that, I'm thinking about this scenario, which is like, oh, they're going through something. I want to see them more often. Well, how would we document that? Or how do we make medical necessity known if someone's worried about getting audited on those extra claims? Thoughts?
What I do normally is, I mean, from whether it's mental health or substance use, I ask them, if they're requesting it or something's come up. I look at the treatment service plan, the treatment goals. How does this align with what's happening, or do we need to modify that based on the death of a loved one, based on the loss of a job, and then when I modify the treatment plan, I make note on the DAP note and a clinical note saying that a personal clinical note that due to life circumstances, adverse life circumstances that came up. They are triggered anxiety, stress, and they're requesting a higher level of services, as the GAT7 and the PHQ determined a higher level, and then upload that into the electronic health file, put it in, and then when the audit comes through, they're able to see the documentation, clinical justification, and that you did your due diligence to document, and it justifies with the treatment plan, the DAP note, and the assessments in the electronic health record that you followed protocol.
Love that. Very clear. What else?
I would say it's the same for us, right, Jen? We have to justify why we're increasing. We have to upload so that in case if we get edited. And then, as Alex was talking about, and remember that when we're doing medical necessity and we're doing assessments, none of the V codes.
Oh, gosh. Yes.
Like therapists, let go of the idea of V codes. Yes, that is it. And it will not get approved if you have V codes. So just let it go. And go find something else. Do consultation to find out, hey, what is it that I'm not seeing based on this necessity and increased symptoms? Because V codes are not going to cut it.
Right. So I'm hearing like update the treatment plan, but also reflect a different diagnosis if appropriate based on what they're presenting with now. It's like that changes the dynamic. And what I'm hearing so far, and Jen, I definitely want to hear from you too, is like it's not even just that the client requests it, right? Like a client can come and say, like, I want to see you twice a week. And that might be for their own reasons, or they might have a belief that that's going to make things go faster in their work, which maybe it will, maybe it won't. But I know that's not enough to justify medical necessity. That's what I'm hearing from you so far. Yes. Correct.
And that's often that's something that I talk about with my supervisees and my team is, okay, do you think they need this? Is that because I think that this is something that, and this is probably a whole nother topic, but we don't want clients to get to a point where they are paralyzed in making a decision before they talk to us. Right. And this kind of like veers into ethical, like, are you making progress? Are you not? Are you? So, I mean, those are things to definitely look at too. Is this true medical necessity, or is this just a comfort level thing with the client? And beyond that, I was going to add that this does just kind of go back to knowing how to play the game. If you're billing for insurance, there is a crisis code if you need to do a longer session. There's a code, there's a modifier for if you need to have a same day session, if you need to have for us, it's if you need to, have a session with your client and you need to have a parent consultation on the same day. There are ways to do that. So, I mean, I think it's more, instead of letting all of those things dictate how you practice, figure out what you need to do clinically, what is actually in the best interest of your client. And then let's find out how to bill it. Let's find out how to code it. Let's find out what language we need to use. Because I think that a lot of therapists really feel trapped by the, well, I have to do it this way, or I can't do this because it's not allowed. So, and I think that that's a barrier to effective treatment, right? I mean, we are trained clinicians. We know for the most part, with our treatment plans and everything else, what our clients need. So if we focus on that and then figure out, okay, how do we make this actually billable? How do we make this, how do we do this in a way that works?
Yeah, I appreciate that distinction.
I was going to say, but it's also name it. So most of us went to school and got a master's degree on how to do therapy.
Yeah.
And what we got there was models and ideas. And some of us got some trainings on how will that treatment plan look, which it's not what it looks like in reality. The school has really good fantasies about treatment plans and notes. And what we're discussing today is that, yes, all of that, and we have to be ethical, and then we have to speak a different language when we're managing systems.
Yes. And the other thing too that I want to piggyback on is that a lot of times people come in with referrals saying they're here for group, and then when you do the assessments, like they're not amenable to group. The clinical justification to put them in individual versus that you document that as well, even though they were referred for group, and you realize that because you heard the client's need, there's more buy-in, because and there's more engagement as well, because you were able to see past just the basic referral and based on the need. And and we take into consideration also where the client is at as part of the medical necessity as well.
Right, right. And so I'm hearing that it's what the client's presenting with authentically. And it's also, we have master's degrees and we know what we're doing. And then it's also educating ourselves on how to work that system of insurance to benefit our client, which I think all of us, embody. And hopefully this is giving some reassurance to people watching this video that it is possible. It takes some effort, but it's possible. So yeah, whether medical necessity is from the start of care, of a referral coming in, where are they appropriate, what kind of levels of service do they need, versus someone who goes into a crisis, increased suicidal thoughts. Maybe there's a life change that I'm hearing from the three of you, something that would justify an increased level of contact. Maybe it's now I'm seeing you twice a week just for a temporary spell to see if we can get you to stabilize, something like that. But the main thing I'm hearing is document it, which of course grad school drilled into all of us, document it or it didn't happen.
Yeah.
So
we did get that.
Yeah. So
yeah.
I think everyone who watches this video can relate to that, because I think that was just like full force, no matter where we went to school. So yeah, any final thoughts as we wrap up this video, knowing that there's probably a lot of more information we could share, but this is just kind of clearing the air around medical necessity and what it is and what it isn't. Any final thoughts?
I would say you're not on an island. Reach out, consult. We've all been there, done that. And trust me, let's normalize the fact that this is a challenge at first. Once you get the hang of it, it's second nature. Yeah.
It does get easier. Don't be afraid to advocate for what your client actually needs rather than what the system is telling you.
Yeah.
They need.
And I will end up with it's a system game. So we have to learn how to speak that language the same way that we had to learn how to translate what happens in sessions to notes. And now it's translating from session to notes to clinical so that we can get approval for what the client needs. Too many languages. All of you are speaking too many languages. Just know that.
You can do
it.
Yeah. You can do it.
Yeah.
But it takes practice and it gets better. So obviously all of us are resources for this. We've all had experience working with medical necessity, whether it was Medicaid, insurance of other kinds, or just advocating for the clients that we serve. So hopefully you're leaving this video feeling more motivated and reassured that even though this might feel like a pain in the ass, it is worth it in advocacy for your client. So we are here for you if you need something. Thank you for the three of you for talking about this. I know it's just come up a lot recently, so I really appreciate you sharing your experience. And viewers, stay tuned for more videos. We'll see you next time.